Dr. Dayspring, we are live. Welcome.
All right, so we'll get this rodeo going here. And I think I have a very interesting topic, but it's going to require every minute that I've been allotted to. So let's get going. The objectives are to review the standard lipid and lipoprotein moieties, their biochemistry, their historical discovery, their assay methodologies, and review how best to use lipid and lipoprotein metrics in everyday practice. Interestingly, I just made this slide today because it was just published today in the Journal of the American College of Cardiology, and it's really the reason why this seminar is going to be so important. They looked at 10-year and 30-year risk of cardiovascular disease in the United States population, and it's data from the National Health and Administration Survey. This is horrific. 3 in 10 U.S. adults aged 30 to 79 years have existing coronary vascular disease or an elevated 10-year predicted risk of CVD, including that being present in 90% of folks who are older than 65 years. 2/3 of middle-aged adults are without CVD but have an elevated 30-year CVD risk. So the whole country should be listening to this lecture tonight. Men and Black and Hispanic adults are at the higher risk. These findings emphasize the need for intensive efforts to prevent cardiovascular disease in the United States. And this is just the graphic there. Remember, above 7.5%, you're at risk. So you look at the height of those bars, the prevalence of those things we just talked about. It's really a minority of Americans who don't need cardiovascular education and cardiovascular therapeutics. So there was an editorial that went along with this study that was published today. And the editorial has put this great graphic. Here's what we need to do. You really should start looking at risk assessment either just before a woman gets pregnant or during pregnancy, because lipid abnormalities during pregnancy influences the fetus and puts the fetus at risk decades down the road. Of course, childhood, pediatric societies recommend cardiovascular screening at ages 7, 8, or 9 in children, and those who have inherited genetic disorders treatment. Young adults absolutely have to be screened. And even in midlife to older adulthood, it's never too late to get in there and do what they are now calling primordial or primary prevention. So now let's get into what we have. If we're going to do that, what do we have to understand? So it's a lipid talk tonight, so I'd like to educate you on what are the various groups of lipids. Virtually all of the lipids that exist can be put in one of these categories that you're looking at there. Well, tonight we're primarily going to be concentrating on sterols, fatty acids, and what's called the glycerolipids. Glycerolipids are basically fatty acids that are attached to glycerol, and I've circled them there. Monoacylglycerol, diacylglycerol, triacylglycerol, better known as triglycerides. And that's where the focus will be on tonight. In a few weeks, I'm doing a talk on brain and lipids, and that's where the glycerophospholipids and the sphingolipids come into play. So, you know, of all the lipids, the one sine qua non for atherosclerosis is you have to have a sterol in your artery wall. And that sterol happens to be cholesterol, and there's its molecular structure there. It's an interesting molecule. It's cyclic, and it has what's called an aliphatic tail. That aliphatic tail is all lipid, and on the left side of the equation, or the molecule, you see a hydroxy group, polar, meaning soluble in water. Non-polar is not. Any molecule that is polar on one side and not polar on the other, meaning water soluble on one side and not water soluble on the other, is called an amphipathic molecule. This is crucial, and it's why cholesterol's main location in the human body is in the cell membranes, because the polar thing can stick out of the membrane and interact with water in the plasma. Now, the storage or transportation form of cholesterol is when that free cholesterol gets esterified to a fatty acid. And that creates a much bigger compound called cholesterol, spelled with a Y-L, not O-L, ester. And that is what you will find in cells who store cholesterol, or in plasma where cholesterol is being trafficked it's in the inert cholesterol ester form. If you would like to make something from cholesterol, you have to deesterifiy it back to free cholesterol, which then can be converted to certain other molecules. Cholesterol ester is just the storage or transportation form. So now we all know lipids are hydrophobic molecules, and the definition of lipids are they're not soluble in water, and of course plasma happens to be pure water. So how in the world do lipids travel through our plasma to get where they're going? Now, my diagrams tonight, blue is triglyceride, yellow is cholesterol or cholesterol ester, and the little brown dots with two legs are the phospholipids, also antipathic molecules like free cholesterol. And that's why most phospholipids are in the cell membranes or on the surface of lipoproteins. Now, nobody has any free cholesterol, cholesterol ester, or triglycerides circulating in their bloodstream as free molecules, because they cannot exist in water. They are oils, they are droplets. So how the heck are these water-insoluble lipid molecules trafficked? Well, evolution said, no problem. Evolution invented something called an apoprotein, which is defined as a protein looking to bind to other molecules like lipids. And you see I put this big brown snake-like apoprotein in my diagram. By the way, several of them exist, and they all are called by the first by a capital letter. And you can see the number of apoproteins that are now existing. There are a few letters that are not used, but many are. Now, once lipids adhere to an apoprotein, they're called apolipoproteins. And once a lot of lipids bind to apoprotein or apolipoproteins, you create a lipid transportation vehicle called the lipoprotein. Now, in my graphic here, you see I've made that particle have a external peptide called apolipoprotein B. That is just about the largest apoprotein that our bodies can make. And it wraps certain particles. And the particles that are wrapped, before they ever discovered ApoB, these were called beta lipoproteins. And there happens to be one ApoB per ApoB containing lipoprotein. Now, they consist of a family. If you take the beta lipoproteins and you put them in a centrifuge, they separate by their buoyancy. The very low density float, the intermediate density sink a little bit, and the low density lipoproteins sink even further. So the beta lipoproteins, there are 3 of them that exist. Now there's another group of lipoproteins whose structural protein is not ApoB, it's apoprotein capital A-1. And there are anywhere from 1 to 5 copies of ApoA1 per HDL particle. And before ApoA1 was ever discovered, these lipoproteins were called alpha lipoproteins. So there are how lipids are trafficked in the human body. When you measure cholesterol in the bloodstream, you are measuring the cholesterol or the triglycerides that are being carried by quantities of these lipoproteins. So now I call this the family picture. There is every lipoprotein that's floating around your body right now. And you see on top, they go from very big to very small. And in the middle, the HDL particles are the smallest lipoproteins of all, very small. And you can almost look at the colors here. And what makes a lipoprotein big? Blue, meaning the lipoproteins that carry a lot of triglycerides are our biggest lipoproteins. And the particles that carry much less or no triglycerides, such as HDLs, are the smallest lipoproteins. And what makes a lipoprotein buoyant or floats? The more lipids that are in the particle, the more buoyant they are. The less lipids, the less buoyant they are. That means they're denser and they sink in the centrifuge tube. And you see the names of them there. And their purpose is to traffic lipids in human plasma. Now, the chylomicron is produced by our small intestinal enterocytes, filled up with a lot of triglycerides. Whatever cholesterol you absorb, it's surrounded by phospholipids, and it's secreted in the lymphatic system, goes up out of the thoracic duct, and enters the plasma. Very low density lipoproteins are like smaller chylomicrons, and the liver produces them and secretes them. But their purpose is the same purpose as chylose, to deliver triglycerides to the tissues that need them. And that would be muscle cells that use the fatty acids from triglycerides for energy, or adipocytes that store the fatty acids as triglycerides for future energy needs. Looking at the VLDLs, but the same thing would happen to chylose, as they undergo lipolysis, that's hydrolysis of their esters, the triglycerides are formed into fatty acids. So as the VLDLs or chylose lose trigs, they become smaller, 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 more dense, more dense, more dense, less buoyant. And sooner or later, they're so small, they cannot be called very low densities. They're called intermediate density lipoproteins. As the intermediate density lipoprotein, or IDL, undergoes further lipolysis, it shrinks and becomes a low density lipoprotein. So that is what we call lipolysis, the loss of triglycerides. All of those particles that are carrying lots of cholesterol do not deliver cholesterol to any cell in your body. They're basically bringing the cholesterol back to the liver. More on that later. So triglyceride removal, the particles get smaller, and that process is called lipolysis, and it's created by lipolytic enzymes, the major one being lipoprotein lipase. So the VLDLs were produced in the liver, the chylose in the gut, HDLs are formed in the plasma. The liver or the intestine can secrete apoprotein A1, the building block, but it gets lipidated to binding to various cells in the body, and it acquires cholesterol, and it gets bigger, 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 and that's why the HDLs from right to left go from very small to very big. So we have the ApoB particles on top, the beta lipoproteins, we have the ApoA1 or alpha lipoproteins on the bottom. So let's dismiss the HDLs for now, and I want to introduce a very important concept called plasma residence time. Once the ApoB particles above are secreted into plasma, how long is it before they are gone? And they get removed because they're cleared by the liver. So you see the chylomicron actually has a half-life of minutes. Its plasma residence time is basically a postprandial hour or two. The VLDLs linger in plasma for upwards of 4 to 6 hours before they're all gone. Any IDLs that are created, they're rapidly cleared by the liver. They last just a few hours. But some of the IDLs are converted to LDLs. And once an LDL is created, notice its plasma residence time is several days. So that means if you're measuring ApoB, and remember there is one ApoB on every one of those particles, because of the very long plasma residence time, 90 to 95% of your ApoB level is an LDL particle count. So really, when you're ordering ApoB, which I hope by the end of this lecture you will be doing on everybody with every profile, you are counting the number of LDL particles. There are more sophisticated tests that will give you an LDL particle number, but ApoB is the easiest, the cheapest, and the most valid. So, but there are other apoproteins, and right now I want to introduce you to one of the more important ones called apolipoprotein E. And as you all likely know, ApoE comes in different isoforms. We get a gene from mom and a gene from dad, and you could get the APO2, the ApoE3, or the ApoE4 gene, or you can get combinations of E2, E3, E4, whatever. And what is the function of apolipoprotein E? Well, here it comes. Several copies of ApoE bind to our very low density lipoproteins and also our HDL particles. Now, the VLDLs are only in the plasma. And ApoE is essential because that is the apoprotein that receptors in the liver bind to clear VLDL particles. And there will be 2, 3, 4, or 5 copies of ApoE per VLDL particle. Without ApoE, the VLDL would never get cleared. But different ApoE isoforms have different affinities for the receptors that are going to clear them. That's a lecture for another day. Now, notice the HDLs also have not only ApoA1, but ApoE, and they can have several copies of ApoE. But HDLs are not only found in the plasma, but it is the only lipoprotein found in the brain. And the brain of HDL particles carry ApoE. Typically not ApoA1 per se, but when you listen to the brain lecture in 2 weeks, you will find out ApoA1 can get into the brain. So that's what ApoE does. ApoE is a receptor to bind to things, but HDLs are the main carrier of ApoE. In the plasma, HDLs carry several copies of ApoE, and when V alleles and chylomicrons enter plasma, the ApoE gets transferred from HDLs to the V alleles. Okay, so atherosclerosis is the disease we do not want to happen, the leading global cause of morbidity and mortality at the present time. So when did we know this? Well, atherosclerosis is derived from the Greek word athera, which means gruel or porridge. In 1856, Rudolf Virchow described the atherosclerotic plaque as a fundamental lesion of atherosclerosis. So we've known about plaque for goodness, that's 175 years or so. Wow, what a smart man. But only now are we beginning to tackle it. There's nothing he could do about it in his day. And there is that cholesterol molecule. And where does the name cholesterol come from? The Greek chole, which means bile, and you'll see in a minute that's where cholesterol was discovered, and stereos, meaning solid. It's basically a crystal, the cholesterol molecule. But it has the suffix OL because it's in the alcohol family, and that's the OH group at the third carbon of the first ring. There is that isooctane, meaning 8-carbon tail, that attaches to carbon 17 of the fourth ring. So, there is that atherosclerotic artery. Now, the sine qua non, or the root cause that people like to talk about atherosclerosis, is one thing. It's cholesterol. If you do not have cholesterol in the artery wall, you do not have atherosclerosis. If you have cholesterol molecules in the artery wall, you have atherosclerosis. That's it. There's nothing else you need in there. By the way, to have atherosclerosis, you don't have to have hypertension, you don't have to smoke, you don't have to be fat, you don't have to have diabetes, you don't have to have terrible parents with bad genetics. You need cholesterol in your artery wall. And the million-dollar question is, wow, so if we could figure out how cholesterol gets into the artery wall and we prevent that from happening, there can't possibly be atherosclerosis in humans. And that is true. So it is, once it's in the artery wall, it gets ingested by macrophages, which fill up with cholesterol. And you see my little graphic there. They form what is called foam cells. Foam cells coalesce, and before you know it, you have plaque. Now, this is a slow process. It takes years, if not decades, to develop. So it's not like if you suddenly had high cholesterol today, tomorrow you're going to get a heart attack. It takes years for cholesterol to build up into this horrible picture that I'm showing in the background there. So cholesterol is absolutely required by humans for cell membrane function and for production of bile acids, steroidal hormones. But it is so crucial to human life that evolution gave every cell in the body the de novo power to synthesize it, but it also gave our intestine power to absorb it. So evolution certainly didn't want cellular cholesterol to be low. Not plasma cholesterol, cellular cholesterol. Plasma cholesterol, it's irrelevant. Every cell in the body makes all the cholesterol it needs. It's a very important point. That means the lipoproteins in your body do not have to deliver cholesterol to your cells. There's a couple of cells that do get a cholesterol delivery, and we'll get into who they are. But the overwhelming vast majority of your peripheral cells, and a peripheral cell is defined as anything that's not in the brain, synthesizes all the cholesterol it needs. In fact, sometimes cells synthesize too much cholesterol, they have to evict it, because you'll see in a moment the cholesterol will kill them. So, cholesterol synthesis and absorption. So let me blow you away with this next slide. A good thing we're not going through every step. This is the over 30 steps that every cell in the body goes through to synthesize cholesterol. Start at the top right, from the 2-carbon acetate or the 5-carbon citrate that comes out of the Krebs cycle. And you can see through several conversions and various enzymes, they form 5-carbon molecules that are called isopentoids, isopentyl pyrophosphate. From there, you go, the molecule gets lengthened until you have a 30-carbon molecule called squalene. 30 carbons is a monstrous linear molecule in the human body. but it's kind of unstable because when it gets that big, it starts to cyclicize on itself. And before you know it, you have the first cyclic molecule that's going to form cholesterol. And it's a sterol, lanosterol. So lanosterol is going to go through several more steps to generate cholesterol. And evolution, I guess in its desire never to have somebody be totally cholesterol deficient within cells, we're not talking about plasma here, they gave it two pathways. So lanosterol can go through something called the Can-Dutch-Russell pathway, and the penultimate or next to the last sterol in that pathway is called lithosterol. But there's another pathway that lanosterol goes through, and the penultimate sterol is desmosterol, which through one enzymatic action becomes cholesterol. This is kind of cool because you and I can measure lithosterol and desmosterol in the plasma, and if it's elevated, we know the person's cells are over-synthesizing cholesterol. If they're low, the cells are not synthesizing cholesterol, but most people hopefully would have normal levels of lithosterol and desmosterol. Now, they could still have high cholesterol because they might be over-absorbing it. These are synthesis markers, desmosterol and lithosterol. Interesting, those isopentyls go through other maneuvers and get converted into molecules that serve as precursors for isoprenoids, which prenylate proteins, which is crucial to altering the function of numerous proteins in the human body. So that's just another essential part of the cholesterol synthesis pathway. By the way, you all know if we prescribe a statin, you see up top, HMG-CR, statins inhibit that enzyme. And if you go up even 2 steps further, bempedoic acid prevents acetyl-CoA from becoming cholesterol. Those are our 2 cholesterol synthesis inhibition drugs. For the production of 1 mole of cholesterol, the body uses 36 moles of ATP. This is an incredibly energy-driven process, and this is why evolution goes to great extents to reuse cholesterol. Very little cholesterol gets excreted unless there is too much cholesterol in the body. It's really any cholesterol that is not absorbed is, they become bile acids and are reabsorbed at the ileum and reused. So this is very tightly regulated. That's too much energy. So how about absorption? In the intestine, there are influx and efflux sterol transporters. They sit right on the cell membrane between the cytosol of the enterocyte and the gut lumen. On the left, you see the Niemann-Pick C1-like 1 protein, which pulls cholesterol into the gut. It also can pull in phytosterols, but they have much less affinity for phytosterols than they do cholesterol. So that's how sterols get in. But you don't want to overabsorb too much cholesterol. Under no circumstances do you want to absorb phytosterols. So evolution gave us a sterol efflux protein at the enterocyte gut lumen border called the ATP binding cassette transporter G5 or G8. So if there's too much cholesterol in the enterocyte, it gets evicted right back out to the gut lumen, as do phytosterols, and they can then be excreted in the stool. So interestingly, if you have loss of function due to inheriting isoforms of Niemann-Pick C1-like 1 gene, you will hypoabsorb cholesterol. And that means from the day you're born to the day you die, you have reduced LDL cholesterol compared to people who did not inherit this loss of function. And because of that, they have significantly less arteriosclerotic heart disease over time. But how about the ABCG5-GA transporters? If you have loss of function of that, you can no longer evict hypercholesterol that was absorbed or phytosterols that were absorbed back to the gut lumen, and that causes sterol hyperabsorption, which increases LDL cholesterol and puts these people at very high risk for arteriosclerotic heart disease. And the more inhibitory the loss of function is, the greater the LDL cholesterol. If you have homozygous loss of function of G5 or G8, you have the very rare disease that originally was called cytosterolemia and now should be called phytosterolemia because numerous phytosterols get hyperabsorbed. And above certain concentrations, phytosterols are incredibly toxic in the human body. All right, back to that diagram. This is why cholesterol kills cells. It crystallizes. If that's a plaque, the bottom right is a histological section of a cholesterol crystal rupturing a plaque, causing a thrombus. So if cholesterol crystals rupture in the cells in your body, that cell dies. So this is why evolution gave every cell in your body a membrane transport, efflux transporter to get rid of cholesterol called ATP binding cassette transporter A1. And that efflux is any cholesterol out of any cell that has too much into a cholesterol acceptor protein, which is ApoA1, and that's how your HDL particles are lipidated in plasma. They save cells from having cholesterol toxicity. Now, does everybody know what a crystallopathy is? That is diseases that are caused by crystal deposits in various cells. Now, certain crystals are needed. If you're a turtle, you need a shell. But if you're a human, you need them to build bones and teeth. But cholesterol crystals in other organs cause acute or chronic injuries, such as calcifications in the vascular walls, tendons, gallstones, etc. So I'll bet you didn't know, if you read this incredible article in the New England Journal of Medicine, cholesterol is toxic because it's in the diseases called crystallopathies. The most famous crystallopathy is gout, which is caused by uric acid crystals. Actually, this gout never killed too many people in the modern era, but atherosclerosis is killing people every day. So people are dying of a crystallopathy. And go down the list. It's gallstones, it's other stones, it's tissue ischemia due to narrowing of arteries. It's hepatotoxic liver disease. Fatty liver is in part caused by cholesterol crystals. So this is why we have to make sure there is never too much cholesterol in the human body. So what lipid molecules are actually present in plaque? Well, I've told you it's cholesterol, right? Is there anything else? I know everybody believes triglycerides is a big risk marker, and it is, but are there any triglycerides in our plaque? Please buy this book and read chapter 1. There are not. You can see the overwhelming majority of cholesterol in plaque, whether it be stable plaque or unstable lesions, which of course have more, is mostly cholesterol ester, some free cholesterol, phospholipids, but almost no triglycerides. Now, triglycerides has everything to do with the ApoB particles carrying the cholesterol into the artery wall, but it's not like triglycerides are going into your artery wall and hurting anybody. All right, I love this editorial, and it was written in 2010 by one of the all-time giants in cardiology and lipidology. Bill Roberts was the actual editor of the American Journal of Cardiology, one of our most prestigious journals, for 41 years. Tragically, he recently died. But Bill Roberts was the editor, and this is one of his most famous editorials. It's the cholesterol, stupid. And in that little article on right, and please download this and read it, the lower the LDL cholesterol, the better. And this principle has been established repeatedly, despite voices of the anti-cholesterol, anti-statin fallacy mongers. It's the cholesterol, stupid. And he could not be more right. I've showed you no cholesterol in the artery wall, no atherosclerosis. Well, after that, here we are now over on the other side of the pond. The European Cardiology Society issued a major treatise entitled Low-Density Lipoproteins Cause Atherosclerotic Cardiovascular Disease. And what is the primary lipids LDLs carry? Cholesterol. This was a 13-page treatise with 53 references. 3 years later, they issued an updated edition that had 343 references over 17 pages with the same title, LDL lipoproteins cause atherosclerotic cardiovascular disease. In between those two things, they issued one of the best guidelines ever written, and I just want to read you some of their conclusions. Continued exposure to ApoB containing lipoproteins leads to additional particles being retained over time in the artery wall and to the growth and progression of atherosclerotic plaques. On the average, people with higher concentrations of plasma ApoB particles will retain more particles and accumulate lipids faster, resulting in more rapid growth in the progression of atherosclerotic plaques. Here comes the good news. The clinical benefit of lowering LDL cholesterol is determined by the reduction in circulating ApoB containing particles, which is usually mirrored by a reduction in cholesterol carried by these particles. LDL cholesterol is just the poor man's guesstimate of ApoB. You have high ApoB, you're what that first slide said, you're on the road to atherosclerotic heart disease. If you lower ApoB to proper levels, pretty much physiologic levels, there's no prayer you will ever get atherosclerotic heart disease, with rare genetic exception. So how did science get to those perhaps startling conclusions I just read to you? Now let's go through how we know so much about cholesterol. It was discovered in 1758 by a French chemist, Francois Pelletier de la Salle, who first identified a wax in solid form in gallstones. Sadly for him, he did not write down the name cholesterol or whatever he might have called it, and his work was never published. It was rediscovered long after his death. Here's the guy with the credit. In 1815, the father of organic chemistry, Michel Eugène Chevreul, he did name the crystals found in gallstones as cholesterine, from the Greek chole and the stereosolid that we told you about. Interesting, look at Professor Chevreul. He lived to the age of 103. Maybe he didn't have too much cholesterol. So cholesterol discovery, let's continue the trail. I hope you've all heard of Nikolai Anichkov. After graduating from the Imperial Medical Academy in Russia in 1909, he and his student fed rabbits purified cholesterol and sunflower oil and actually induced atherosclerosis in those rabbits. And look what he discovered, those foam cells that I talked to here. That's his drawing back in 1909. The first guy who drew foam cells, and you can see the German pronunciation of foam cells under that diagram. I'm not going to attempt that. He was the first to make the connection between cholesterol and atherosclerosis. Virchow discovered atherosclerosis, but he didn't know it was cholesterol causing it. And Anichkov proved it. So he created the origin of the cholesterol hypothesis. How important was that? It is considered one of the 10 greatest discoveries in the history of medicine and mankind. This is a great book written by 2 Yale professors about 10 years ago. And Anichkov's discovery is in the top 10. They didn't rank them except for number 1. And the number 1 most important discovery was Harvey, for discovering the heart and the circulation. Very apropos for tonight's talk, both Anichkov and Harvey. So continuing, Adolf Emil Reinhold Windhaus was a German chemist who in the early 20th century did a lot of research on sterols and vitamin D. Concomitantly, Heinrich Weyland was a German chemist whose research was bile acids, which of course are derived from cholesterol. And they did their early work in the early 1900s. Belatedly, they received the Nobel Prize in 1928 for their work on cholesterol. So here's the father of lipoproteinology, Michel Macbeuf. He was a French physician and biochemistry scientist at the Pasteur Institute, who was the first to notice that serum lipids are chemically bound in blood to the proteins. He isolated in crude form from horse serum protein moiety, which was different than albumin and other globulins, and he called them acid precipitable synapses. And later they were proven to be, he discovered, without knowing it, high-density lipoproteins. He is now called the father of lipoproteins, the first to associate lipids with proteins. So it was in 1934 that the first simplified assay for cholesterol was discovered by Rudolf Schirnheimer. Luckily, he escaped out of Germany and did his research in New York City at Columbia. And we finally had an assay that was mostly used by researchers at that time. And it was an accurate, rapidly, and relatively simple procedure that determined free and total cholesterol in the blood or any tissue you were looking for cholesterol. And it actually precipitated with a molecule called digitonin, which is derived from the digitalis plant. And by binding it, they could precipitate it and count it. Now, until the 1940s, most people still believe cholesterol is like potassium, sodium, whatever. It just was a molecule floating in the bloodstream. Not a lot of people were familiar with what McBook had discovered a few years earlier. So Arne Celius developed a new electrophoretic technique where he could isolate many things. He mostly developed it to separate proteins in the blood. Using his apparatus, Fridtjof Gunnar Bliss revealed that electrophoretically separated proteins, both albumin, alpha, beta, and gamma globulins, all contain cholesterol and phospholipids. But it was the alpha and beta globulins that carried the vast amount of cholesterol in the body, and hence the terms beta and alpha lipoproteins. He was the first to notice that if you've got cholesterol in your bloodstream, it's being carried by proteins. And they didn't know what those proteins were. The particles carrying them were called alpha and beta lipoproteins. But it took them a long time before they discovered that it was ApoB and ApoA1. And this is a modern electrophoretic. In the patch, you will separate the various lipoproteins. You see the purple colors on a gel. And lipoproteins have electrical charges, so they either migrate toward the anode or the cathode, and that's how they separate. And therefore, you can separate distinct areas where HDLs, Lp(a), VLDLs, and IDLs exist. This is called an electrophoretic. It's not used that much anymore when you order lipids, but at one time it was. So Dorothy Crawford Hodgkin, we finally have a woman in the scenario, was an English chemist who used X-ray diffraction and crystallography to identify numerous sterile molecules and unambiguously, for the first time, demonstrate cholesterol structure. And that was 1945, and Nobel Prize. Everybody's heard of the Framingham Heart Study. Few remember that Tom Dauber was the first director and Bill Kennel the second. And this began in Framingham, Massachusetts as a long-time cardiovascular research project where they enrolled virtually the whole town into getting a whole bunch of cardiovascular tests over the years. And it's still going on to today. Bill Cannell was the first to invent the term risk factors. Later on, everybody perhaps have heard of William Castilli. He was the third director, recently died also. And there have been subsequent directors after them, but they're the most famous directors. Now here is the king. John Goffman, a nuclear physicist who also went and got an MD degree, working with his grad student Frank Lundgren, and stole the Donner Laboratory ultracentrifuges that were used by the physicists who created the atomic bomb. And once that was created, they didn't need their centrifuges anymore. So he could stick serum in the centrifuges, and he's the one who successfully separated lipoproteins by their buoyancy and density. Several years later, Richard Havel invented even a more sophisticated centrifugation, the preparative quantitative ultracentrifugation, which became the gold standard, and some still consider it still the gold standard to separate lipoproteins. In 2007, Goffman received the very prestigious honorary membership in the NLA, and he is now called the father of clinical lipidology. So we can separate lipoproteins like he did by their buoyancy in a centrifuge. The ones up top float, they're buoyant. The ones on bottom, which contain few lipids, sink, they're dense. But we can also separate lipoproteins by their diameter. And when we go right to left, very tiny, to all the way on the left, it's gigantic. Any lipoprotein that is less than 70 nanometers in diameter can crush your artery wall. And there they are. And up top, you see the beta lipoproteins, and on bottom, you see the alpha lipoproteins. The ApoB particles have one ApoB per particle, so they're very easy to count. Unfortunately, the HDLs have 1 to 5 ApoA1s per particle, so measuring ApoA1 cannot be used to count HDL particles. It's not a metric that has much use now. It may again in the future, and stay tuned for that when we get to the brain lecture. So there they are. The biggest lipoproteins are the ones that are most triglyceride rich. As they deliver their trigs, they become smaller, smaller, and smaller. You can see LP little a, and we're going to have a whole lecture on that next week, is a minority member of the LDL family. So, continuing with the experts, in 1942, Rittenberg discovered that, cholesterol comes from step one, which is acetic acid, is the acetate, the major building block. It's no wonder why people who get ketotic, that build up a lot of ketone bodies, very often have tremendous cholesterol synthesis and very high LDL cholesterol and ApoB levels. Later, the work of Conrad Bloch and Fyodor Lenin, and they worked separately. One was in Germany. Conrad Bloch was a Polish citizen who migrated to the States. Fyodor Lenin was a German scientist who did not have to abandon Germany in World War II because he was a German. And they basically, all those steps I just showed you in cholesterol synthesis, they were the ones who discovered them. And they obviously were awarded the Nobel Prize for such an immense discovery. So why the heck, there's a lipoprotein. What do they do with the lipids they're trafficking? Well, we had an answer back in the 1950s, and it was published in a nice treatise in 1966. And of all things, a German manuscript. You see, the journal was called Lipoidy. So now, before that came out, a year earlier, this immense article was published in the New England Journal of Medicine, where for the first time they identified lipoprotein phenotypes then were associated with pathologies. And Bob Lees joined them for that treatise. By the way, if you really want to know lipids, this is a mandatory download. It's free. There's 5 parts to it. If you read it slowly but surely, you will be on your way to mastering lipidology. So they go in, they said, what is the major function of plasma lipoproteins? It's one thing. It's to bring energy, triglycerides from the gut or the liver to muscles or fat cells. That's why we have lipoproteins primarily in the body. Now, in a fasting state, the trigs have all been delivered. There are no more chilos and very few VLDLs. Most of the lipids in plasma then are not triglycerides, it's cholesterol, which are carried in the smaller LDL particles of beta lipoprotein, but also in the HDL particles. And of course, all lipoproteins carrying phospholipids, because phospholipids locate on the surface of the particles, and that's one reason lipoproteins, in addition to their apoproteins, are soluble in water, because phospholipids, like free cholesterol, can interact with plasma. So that's the major function of phospholipids. But right there, I show it to you on a beta lipoprotein. But when the VLDLs and chilos shrink, they shed phospholipids, which go left to right, bind to a carrier protein called phospholipid transfer protein, which brings them over to unlipidated ApoA1, phospholipidates them, and that's how baby HDL particles evolve into more mature HDL particles. They gather phospholipids first, and the phospholipids primarily come from the lipolysis of the big triglyceride particles, which have tremendous surface area and shed a lot of phospholipids. Now, follow this. There is some net movement of cholesterol in the plasma, but it is small proportions compared to triglycerides. Just a few grams per day of cholesterol. Some 1 to 2 grams come from the intestine and the lymph, and it joins in the plasma an unknown quantity, small as it is, in cholesterol, moving from unknown tissues to the liver. We now know that is cholesterol that HDL particles has pulled out of various tissues in the body. So the cholesterol that's being trafficked in the blood is primarily in the LDLs and the HDLs. Now, these are 3 geniuses, actually gastroenterologists who were very much into bile and therefore cholesterol. This is another mandatory reading if you ever want to truly be a top-level lipidologist. The liver is the overwhelmingly important site for LDL clearance from the plasma in every species in which quantitative data are available. The small intestine and all of the remaining extrahepatic tissues account for maybe 30% of the remaining LDL cholesterol. Within this latter group of large and important organs, such as the muscle and the brain, they take up 0 cholesterol from the lipoprotein circulating in the plasma. Thus, in the whole animal, and presumably in humans, most cholesterol is synthesized and utilized in the extrahepatic organs, while most cholesterol carried in LDL is basically on its way back to the liver. Ergo, LDLs are one of the primary reverse cholesterol transport particles. Now, if we measure cholesterol in the tissues of the body, and we're looking at everything here in the periphery, not the brain, you can see the peripheral tissues carry way more cholesterol in toto than do the liver and for sure circulating lipoproteins. But is there anything in the blood that carries more cholesterol than lipoproteins? Where is the circulating cholesterol in the blood? Well, there's a heck of a lot of it more in red blood cells than there are in lipoproteins. And red blood cells, look at the size difference between erythrocytes and LDL particles. Goodness. And where is the cholesterol? They have cell membranes. They're not nucleated. They have cell membranes. So all of the cholesterol in red blood cells is in the red blood cell membranes. Now read this incredible article. The study has established that red blood cells actively participate in systemic lipoprotein metabolism and can potentially influence trafficking of cholesterol in the blood between the blood and vascular cells. So the membranes can accept cholesterol from lipoproteins, they can supply cholesterol to lipoproteins, or they can supply cholesterol to cells. Here is so important. CNS cholesterol, although significant in mass, is not considered in these models, as it does not exchange cholesterol whatsoever with any other body pool. That means it doesn't get cholesterol from any organ in your body, and it certainly doesn't get cholesterol from any circulating moiety like lipoproteins or red blood cells. So the brain has to make all its own cholesterol. Thus, you can lower somebody's LDL cholesterol to 10 and have no effect on brain cholesterol whatsoever. And we now know that people with genetic hypo-beta-lipoproteinemia don't have CNS problems. And people with drug-induced lowering LDL cholesterol do not have CNS problems related to deficiency of cholesterol in our plasma. So here's the story. When a cell has too much cholesterol, to prevent it from crystallizing, to efflux it, the cell creates ATP binding cassette transporters, which effluxes out the free cholesterol and phospholipids to ApoA1. And that forms the baby pre-beta HDL particles. There's an enzyme that esterifies the cholesterol. It becomes a bigger molecule. It goes to the core of the particle, and that's how you generate the large mature particles. The majority of cholesterol molecules within HDLs comes from lipidation at hepatocytes and enterocytes, not from the peripheral tissues, and certainly not from plaque. Any cholesterol that HDLs are pulling out of plaque is not even measurable and does not contribute to plasma HDL cholesterol. The HDL then delivers cholesterol ester to steroidogenic tissue or adipocytes. It's the one lipoprotein that can deliver cholesterol elsewhere. LDLs just bring it back to the liver. But HDLs can, if needed, supply adrenal cortex or gonads, or adipocytes, which is the major storage organ for cholesterol in the human body. This enables both HDLs and LDLs to return cholesterol to the liver in pathways that are called direct and indirect cholesterol transport, or if they bring it to the gut, it's called transintestinal cholesterol efflux. Here we go. Here comes that big fat cholesterol-laden HDL particle. And of course, in the plasma, it's going to bump into LDL particles. Connecting the two is a transfer protein called cholesterol ester transfer protein, CETP. And HDL sends its cholesterol over to the ApoB particles and in return accepts triglycerides. And the LDL, which is now far more cholesterol rich because it accepted so much cholesterol from HDLs, is rapidly cleared by the liver. So you can see the reverse cholesterol transport is the HDL gathering it from cells, but then transferring it to the LDLs that bring it back to the liver. Now, the HDLs can also, in part, bring it back to the liver or the gut. So we have two pathways of reverse cholesterol transport. When an HDL brings it back, it's called direct. When an LDL brings it back, it's called indirect. Total reverse cholesterol transport is the sum of indirect and direct. And how does the liver get all this cholesterol? By upregulating receptors. So it's receptor-mediated internalization. The LDL receptor-related protein binds to ApoE on the chylomicrons and the VLDL particles. Remember, the chylos are carrying all the cholesterol that you absorbed from your gut. Chylos don't deliver cholesterol to any tissue in your peripheral cells. Neither do VLDLs. Once they deliver triglycerides, they return their cholesterol to the liver. The LDL particles, which do not carry ApoE but carry ApoB100, are bind to LDL receptors and are cleared into the liver. So those are major sources of cholesterol for the liver. And of course, HDLs can be delipidated, not internalized primarily, but delipidated at the liver by scavenger receptor B1. By the way, if you have loss of function of scavenger receptor B1, you have HDL cholesterols in the 180, 200 milligrams per deciliter range, and it's associated with coronary atherosclerosis because obviously you can't get cholesterol back to the liver. So the HDLs give it to the LDLs, which bring it into your artery wall. So this is so crucial to understand. The LDL receptor was discovered by Michael Brown and Joseph Goldstein in the 1970s. And they also discovered that HMG-CoA reductase inhibition causes the liver to upregulate LDL receptors. And there is the diagram in the very famous article published in 1976 in the journal Science. And as you see on the top, for that, they were awarded the Nobel Prize. And you know what followed that? A Japanese professor called Akira Endo. And this is an incredible article if you ever want to get it and read it. Inspired by Fleming's success with molds, we began a project using culture broths of thousands of fungi in April 1971. And a year later, they found a culture that showed potent HMG-CoA reductase inhibitory activity. The active principle turned out to be a molecule called citrinin, which lowered cholesterol level in rats, but unfortunately destroyed the rats' kidneys too. So that product was never developed. But further research, they found other molds from fungi that were safe, that reduced cholesterol by inhibiting HMG-CoA reductase and did nothing to the kidneys. So from that, they got involved, and his wonderful statement said, "My life is I had set my sights on finding a competitive inhibitor of HMG-CoA reductase, and the molecule he discovered called compactin, illustrated at the right, was a wonderful gift from nature. Everybody thinks statins are synthetic. The first three were derived from molds and fungi. That's as natural as you can be." In November 1986, Merck took the compactin derivative, called it lovastatin, and it was approved by the FDA as the first statin in 1987, sold commercially as Mevacor. Now, just recently, my friend Alan Ramali at the NIH really took us into the stratosphere about teaching us about the LDL receptor. We were a bit wrong with previous thoughts. It turns out there's apolipoprotein B. And it shows you that it has two giant beta sheets on what he calls the west and the east hemisphere, and three alpha extensions that are the red that are much smaller. And that's how ApoB enwraps the ApoB containing particles. But ApoB then becomes bind to the LDL receptor, which is a heterodimer. So actually two LDL receptors merge together and they bind to two LDL particles, hence clearing two at a time. It makes it much more efficient for the liver to clear LDL particles. So this display shows you all the incredible discoveries of the various moieties of apolipoprotein B. You can see what a gigantic apoprotein is, explaining its 550 kilodaltons molecular weight. So here's what he showed. The LDL receptor is two heterodimers which go together, and they grab two ApoB containing particles at the same time, and then they internalize them. And the ApoB particles can be digested, but the LDL receptor, if you're lucky, can be recycled. And it's recycled numerous times over a day or two. and that is very efficient for clearing the ApoB particles. All of the drugs that we now use that have successful cardiovascular outcome trials that are approved to lower LDL cholesterol work by either upregulating LDL receptor extension or by permitting increased recycling of LDL receptors. And the latter would be the PCSK9 inhibitors. The former would be bempedoic acid, statins, and ezetimibe. Impaired clearance of ApoB particles is why so many people have increased ApoB. They have more particles than LDL receptors that can clear them. It's not through overproduction of ApoB particles for the most part. It's through impaired clearance. And the only successful way to combat this disease right now is to clear ApoB particles. Increasing the number of LDL receptors is the only way to lower ApoB to the levels that it now must go down to. So atherogenesis is in a nutshell. There's your endothelium, there's the intima, there are your ApoB particles, 95% of which are LDLs. They go through the endothelium. They can just transcytose through normal endothelium. They can easily slip through diseased endothelium. And the size of the LDL is irrelevant. Big LDLs or small LDLs can easily slip through and enter the artery wall. Over time, the macrophages go in and ingest them, creating foam cells, and now you have atherosclerotic plaque. It begins as fatty streaks in kids and just gets more complex as we give it more time. So it's the invasion of the ApoB particles, 95% of which are LDLs, that deliver cholesterol, the sine qua non of atherosclerosis. So now we go on to what should we do about it. So DeWitt Goodman was the first, he was the director of the first national guideline that taught doctors about cholesterol and how to treat it, published in 1988. And I'm not going to belabor that, but if you read those names, it's many of the geniuses of lipidology, several of whom are still alive. I see Ernie Schaefer in the top, and he's now the director of Boston Heart Lab, and you will recognize many other names there. Interesting as to what they said. Total cholesterol levels are classified as follow: less than 200, desirable; 200 to 240, borderline; above 240, high. And they said, by the way, if you see high total cholesterol, put them on a diet, and if after 6 months they have not lowered their cholesterol metrics, and it was mostly total cholesterol that was being measured, then they need a drug. And they didn't have a lot of drugs then, but they were on the horizon. In 1994, we got the second version of the National Cholesterol Education Program. Chairman was the great Scott Grundy, who unfortunately passed last year also. And in 2001, we got NCEP ATP3, Adult Treatment Panel 3. And that was the last guidelines the government ever put out. But this lasted well over a decade before the American Heart Association started taking over with guidelines. And the executive summary was published in 2001 and 378 pages a year later. And again, I tell budding lipidologists, youngsters, you want to learn lipids, this is still an incredible free document. I've read every word of that at least twice. And I think if you think I know something about lipids, a large part of my knowledge came out of that treatise. So there it is over time. You go from ApoB particles going into plaque that you don't know you have, unless nowadays we have more monitoring imaging. At step 4, the plaque ruptures, causing a clot, which causes ischemia or infarction. And if you survive that, you're into tertiary prevention. If you have calcium in an artery, you can discover it. But you could have a lot of plaque that doesn't have calcium, soft plaque, and that would require other types of imaging. So primordial prevention, remember what the first editorial, slide 2 said? You got to recognize, discover early in life when ApoB is high and start chasing it. That means you got to do risk assessment and looking at the lipids. Here we go. So just quickly, we use metrics to evaluate lipids. And this is the metric system there. And the surrogates we use to evaluate lipids are, do we use meters or length? Yes, we do, because a cubic decimeter is a liter. So that's how we create volume, using meters. Kilograms are for weighing something in mass, but there is something called moles. So lipids and lipoproteins are either measured as mass, they put them on a scale and they weigh them. If I went on the scale this morning and I'm 70 kilograms, that's my weight. So if you're getting a LDL cholesterol in milligrams, they're extracting the cholesterol from all the LDLs and weighing it. But moles are a different animal. Mass is the collective weight of all the molecules, but a mole is you're counting whatever. Number of molecules, number of particles, number of substances, whatever. Technically, a mole is the quantity of substance that contains as many molecules as 12 grams of carbon, which is element 12. The number of atoms in a 12-gram sample of carbon-12 is called the Avogadro's number. It's 6 times 10 to the 23rd, and 10 to the 23rd power is called 10 sextillion. Thus, 1 mole of whatever is 6 times 10 to the 23 molecules or particles. So if you're measuring lipoproteins in molar concentration, you can see it's an immense number. A mole of whatever is 60 times 10 to the 23rd. 1,000 moles of whatever is 6,000 times 10 to the 23rd, 10 septillion of whatever. Now, where we measure lipoproteins, we're using very small molar concentrations. A millimole is 1,000th of a mole, a micromole is 1,000,000th of a mole, and a nanomole, which is how most of our lipoproteins are reported, is 1,000,000th, 10 to the minus 9th of a mole. So just keep these numbers in mind. So a standard lipid panel reports lipid, not lipoprotein concentrations. And you see, so you get mass measurements when you order a lipid profile. They're weighing the various lipids. Lipid concentrations are basically poor man's surrogates of what type of lipoproteins you may have. Now, using NHANES, you see there are population percentile cut points of healthy and unhealthy lipids. So healthy is sort of under the 20th percentile, physiologic is under the 5th percentile, and anything above the 20th percentile, you're heading down the world of risk. So the only lipid metrics that are used as either primary or secondary goals of therapy and guidelines are LDL cholesterol or non-HDL cholesterol. Does everybody know there is no total cholesterol goal of therapy? There is absolutely no HDL cholesterol goal of therapy. I am so tired of hearing people telling me, oh, how do I raise HDL cholesterol? Why would you want to? And there is absolutely, although it's a risk marker, there is no goal of triglycerides. What if you have a high triglyceride, what level do I have to lower it to get no risk? There's not a trial that would give me the answer to that question. So therefore, you cannot use triglycerides or HDL cholesterol as goals of therapy. Now, it's desirable to lower triglycerides. It's irrelevant whether you raise HDL cholesterol or not. So let's prove this to you. In 1958, one of the top cardiology in a very primitive specialty called cardiology was Paul Wood in London. And his textbook was the first seminal work in the field of cardiology. Everybody referred to it. In his book, he said the total serum cholesterol is normally around 150 to 300 and is certainly related to atherosclerosis, but it's a very crude measure of blood lipid disturbance. Cholesterol is insoluble in water and carried in microscopically invisible macromolecules, and it is the beta lipoproteins that cause atherosclerosis, even when blood cholesterol is normal. Hurst and Lowe were really the authors of the most famous early American textbook in cardiology. Big professors, very much interested in cholesterol. And in their textbook, hey, cholesterol is distributed throughout all of the lipoprotein fractions of the plasma. The preoccupation of cholesterol as cause of atheromatosis has probably been attributed to the fact that it's easy to measure. It is the beta lipoproteins that are the agent for atherosclerosis. And along came Peter Apolovic, who was the first guy who said, we have to start measuring apolipoproteins. And the technology was invented, doing it using ELISA, enzyme-linked immunosorbent assays. And very easy, you take an antibody, you bind it to whatever protein you want, you put in a coloring agent, and you measure it. Brian Brewer was the first one to ever totally discover every amino acid in apolipoprotein B, 560 of them. I'll give you time to write down all the amino acids, which you would need a magnifying glass. Now, this is crucial reading. 18 years ago, and many of these authors are still alive and are top lipid leaders. All of the national and transnational guidelines are based on total or LDL cholesterol. This presumes that cholesterol is the most important lipoprotein risk variable. On the contrary, risk appears to be more directly related to the number of circulating particles that contact and enter the artery wall, rather than to the cholesterol inside those particles. Each of the particles carries a single molecule of ApoB, and therefore a direct measurement of ApoB is the best way to quantitate atherogenic lipoproteins. And evidence from virtually every trial supports that conclusion. So 18 years ago, they wanted ApoB to be what we should be measuring and what we should be acting upon. And as you know, that's still not done. And recently, ApoB has been standardized by one of the top ApoB chemists in the world, Jean Cantois, and the clinical godfather of apolipoprotein B, Alan Snyderman of Canada. And they wrote, variation in the mass of cholesterol in ApoB particles is substantial and is the consequence of so many things that affect lipolysis. No improvement in the measure of LDL-C or non-HDL-C will ever overcome the superior that ApoB has over them. The fact that ApoB can be measured more accurately, precisely, and selectively than LDL cholesterol and non-HDL cholesterol using inexpensive standardized methods strongly agrees for its wide application. And now the World Health Organization has a standard that laboratories can use. Last year, the National Lipid Association issued a major treatise on apolipoprotein B, authored by Dan Suffer. ApoB and non-HDL-C stratify ASCVD risk more accurately than LDL cholesterol. Discordance between those and LDL cholesterol is common. With discordance, ApoB and non-HDL cholesterol correlate more closely with ASCVD risk. ApoB thresholds are proposed in this treatise. Get it and read it. So there is your ApoB concentration. It's all of the ApoB particles. And you can see, you can measure it in milligrams per deciliter. You can convert it, since we know the molecular weight of ApoB, to molar concentration if you want. And you can see in that green bullet point, it tells you what to do. Total LDL-P is small plus large LDL particles. 95% of your ApoB particles are LDL, so ApoB is really an LDL particle count. Some labs break down the various lipoproteins into small LDLs, large VLDLs, increased LDL or VLDL size. And if abnormal, they are basically telling you this person is insulin resistant. But what's the goal of therapy in an insulin-resistant person? Make ApoB normal, not to make small LDLs disappear per se. All right, and this is from the new NLA treatise. It gives you all the population percentile cut points of LDL-C, non-HDL-C, and ApoB. And it's basically ApoB is the superior predictor and more closely associated with ASCVD risk. So look at this. On the top, big LDL particles. On the right, small LDL particles. At the same level of LDL cholesterol, people with small LDLs will have upwards of 70% more particles. It takes a heck of a lot of more small LDLs than big LDLs to carry a given mass of cholesterol, hence discordance. And how about this? Exact same LDL particles, exact same LDL cholesterol level, but the particles on the right are triglyceride-rich and hence cholesterol-depleted. So it would take many more triglyceride-rich, cholesterol-depleted particles to traffic a given LDL cholesterol mass. And this is why triglycerides drives ApoB through the roof. So you see on the left, a normally composed LDL particle, the ratio of trigs to cholesterol ester is 4:1. On the right, you see a triglyceride-rich HDL, which would obviously be a cholesterol-depleted, LDL particle, and it would take many more of them to carry a given level of LDL cholesterol. So what drives ApoB is not only the size of the particles, but it's the composition of the particles. And, few people are measuring LDL triglycerides, which would be a very telling test. Here we go. At a given level of LDL cholesterol, let's say it's 100, which would be considered, but what would your LDL particle count or ApoB be? Well, it might be perfect at 1,000 nanomoles per liter. It might be spectacular at 600 nanomoles per liter, or it might be lethal at 1,900 nanomoles per liter. And this is why you cannot bet anybody's life on LDL cholesterol. You must measure LDL-P, or better yet, ApoB. When ApoB or LDL-P is discordant with LDL-C or non-HDL-C, the risk is better followed by the particle number. So now in a standard lipid panel, you know what you get. You get total cholesterol. The LDL cholesterol is mostly calculated, still using an old outdated formula, but some people measure their LDL cholesterol directly. HDL cholesterol is a direct assay. Non-HDL cholesterol is a calculation. Triglycerides we'll talk about. 4 of the 5 metrics are cholesterol metrics. Never confuse lipid concentrations with lipoprotein concentrations. They are surrogates or guesstimates, but they are not lipoprotein concentrations. So LDL cholesterol may suggest that your ApoB or LDL particle count is high and low, but it's a guess, and it could be wrong. At best, lipid concentrations are poor man's surrogates of lipoprotein concentrations. So the first usable assay was actually developed when I was a resident way back in 1974. And we actually started measuring. And I'm not going to go through how they did it. But notice they talk about, hey, you can now order an SMA-12 and get our automated enzyme. And in 1974, when we were measuring, we didn't order complete metabolic panels or comprehensive panels. We ordered SMA-12s. And you can see there are 12 blood tests in it. You see them on down the bottom. But let's just zero in on the cholesterol. And the gray is the normal range. So a normal cholesterol, and it was total cholesterol that was measured. They didn't have LDL cholesterol until several years after that, was anywhere between 150 and 300. So if you saw a patient with a total cholesterol of 290, you were telling them they were normal. Yet we know now that is pretty extreme familial hypercholesterolemia. So this is how we currently develop the assay for cholesterol. They basically hydrolyze the cholesterol ester and combine the cholesterol with other molecules, and there's create a color creating agent, and the absorbance is red, and that's how they measure the concentration of cholesterol. By the way, your cholesterol assays cannot differentiate cholesterol from lithosterol, desmosterol, or any plant sterols you may have absorbed. It measures all of the sterols. So let's look at total cholesterol. Total cholesterol is the mass of cholesterol in all of the particles floating in your bloodstream. But the vast majority of particles are the ApoB particles. So total cholesterol is like the first mini surrogate of apolipoprotein B. The higher your total cholesterol, and I suggest any total cholesterol above 150, you're likely going to find an abnormal ApoB concentration. By the way, since all of the majority of total cholesterol is in the LDLs and HDLs, not VLDLs, you don't have to fast for total cholesterol. Now comes, LDL cholesterol. Now it can be calculated or measured directly. So, and it is the mass of cholesterol carried within all of the LDL particles that exist in a deciliter of our plasma, or if you're using molar concentrations, a liter of plasma. Most labs still use the Friedewald formula. There are more modern calculations that are available, but not every lab uses them. You see the Friedewald calculation developed by Bill Friedewald in 1972 when I was a PGY1. And it took several years for that to come to fruition when we really started looking at LDL-C. So you simply take total cholesterol. From it, you subtract HDL cholesterol, and you also subtract VLDL cholesterol, which is calculated by dividing triglycerides by 5. That's why you have to fast for a calculated LDL cholesterol. But the direct LDL cholesterol assays, which are only zeroing in on the LDLs, not also LDLs, you don't have to fast. It has nothing to do. The triglycerides are in the calculation, or in their excluded from their assay. By the way, whether you do a directly measured LDL-C or a calculated LDL-C, LP(a) cholesterol, if that is a factor, is included in those metrics. Since the vast majority of ApoB particles are LDLs, LDL cholesterol obviously serves as a surrogate of apolipoprotein B. and stop calling it bad cholesterol. Half of the cholesterol in LDLs came over from HDLs when you used to call it good cholesterol. Now it's in an LDL. But if the LDL is returning it to the liver, as the vast majority of them do, that is not bad. That's good. It's doing what LDL should be doing, bringing cholesterol back to the liver. You have no way of knowing what cholesterol is going into the artery or not. You can count the ApoB particles, but that's bringing cholesterol, be it a few molecules or a lot of molecules, into the artery wall. So stop calling it bad cholesterol. So the liver creates VLDLs, which undergo the lipolysis I spoke about by the enzyme on the top there in green, lipoprotein lipase or hepatic lipase. And as you hydrolyze the trigs, you lose phospholipids, and the particles become smaller. They become an IDL. Further lipolysis creates an LDL, which hangs around for 2 to 3 days or longer. Few are unfortunately taught that the liver secretes a heck of a lot of LDLs. Not every LDL is the grandson of a VLDL. So 40% of your plasma LDLs just were produced by the liver and shipped out. They have nothing to do with the VLDLs. So just understand that. Now, as triglycerides go up, the liver tends to make more VLDLs and less LDLs, but there's still a substantial number of LDLs created by the liver. So here's your metrics. Total LDL particle count, LDL-P, consists of big, small LDLs plus any LP(a) particles you have. LDL cholesterol is the cholesterol within all of those particles. Small LDL cholesterol is the cholesterol mass in your small particles. Large LDL cholesterol is the cholesterol mass in your big particles. Total LDL cholesterol is the cholesterol in all those. You see LP(a) cholesterol in the vast majority of people who do not have a high LP(a), it's a non-factor. Even in people with high LP(a) particles, there is still a minority LDL, so they contribute a bit more, but not a lot to LDL cholesterol. Jim Otvos developed the nuclear magnetic resonance protein analysis. You all know that is NMR. By sending in waves from magnets, the lipoproteins start, the hydrogen groups on the terminal methyl groups start oscillating, and that can be measured, and they create spectral signals, which can be deconvoluted to particle and cholesterol and triglyceride concentrations. Many of you who use Quest might be getting LDL particle count, but they don't use NMR. They use ion mobility transfer. And on the bottom, you see how that works. The lipoproteins are ionized in an electrospray generator. They are then shot in an aerosolized medium, and the lipoproteins being ionized, electric current is turned on, and they separate as they would in a gel electrophoresis. And then that is transferred to a particle counter. So they generate LDL or HDL particle counts. That is there. So I ask you, can high-density lipoproteins ameliorate atherosclerosis? And if so, is that protection dependent on the cholesterol in HDLs? What is HDL functionality? Whatever it is, it has zero to do with HDL cholesterol. It's related to all those other and many other processes which we cannot measure. So we have no way of measuring HDL functionality or dysfunctionality, but understand it has no relationship whatsoever with HDL cholesterol. What is the origin of cholesterol within the HDL particles? Well, it accepts cholesterol being efflux from cells. Most of it comes from hepatocytes or enterocytes. A minority comes from peripheral cells. What is the destination of cholesterol within the HDL particles? They bring it to the liver, to the enterocytes. They share it with adipocytes, steroidogenic tissue, or they share a lot of it with LDL particles, which returns it to the liver. This is the history of discovery of HDLs between 1951 and 2008. And you can see it was a slow process. And, you know, we started to understand the ApoB particles long before we really started to understand the HDL particles. But we're getting there. So if you look at the standard lipid panel, you see HDL cholesterol, which is simply the mass of cholesterol within all of the HDLs in a deciliter of your plasma. It is not a metric related to reverse cholesterol transport or to HDL function. It is not a goal of therapy. Stop calling it good cholesterol, because you don't know what the HDL is doing with its cholesterol. What if it gives it to an LDL and the LDL brings the cholesterol it just accepted from an HDL into the artery wall? So is that good? So you have no clue where the cholesterol and HDLs are going. There are people with high HDL cholesterol who get various pathologies, and there are people with low HDL cholesterol who do not. So it's an old term that should no longer be used. So if we're looking at particle metrics, you got ApoA1 or HDL particle counts. So if we use NMR or the ion mobility, you actually get an HDL particle count. ApoA1, since there is 1 to 5 copies of ApoA1 per particle, it cannot serve as a legitimate HDL particle count. And you see ApoA1 is reported in milligrams like ApoB, but HDL particle count is reported in micromoles by NMR. And of course, HDLs are gender specific, so there are different ranges. Due to HDL's long plasma residence time, fasting is not required. And once again, neither ApoA1 or HDL-P tells you anything about HDL function. So to look at this, little baby HDLs gather phospholipids and cholesterol, and they become bigger, bigger, bigger HDLs as the cholesterol gets esterified. Up top, you see the nomenclature that is used by the technique at Boston Heart Lab, two-dimensional electrophoresis and ApoA1 staining. But there are many other methodologies. NMR calls them H1 to H5, small to big. The centrifuge, it's 3C, 3B, 3A, 2A, 2B as you go from small to big. So it's very confusing. So total HDL-P by NMR or ion mobility transfer is the number of alpha HDL particles. It is not, those methodologies cannot count the pre-beta or unlipidated ApoA1. HDL-C is primarily a reflection of the cholesterol in the two biggest HDL species. Anybody with low HDL cholesterol is lacking the two big HDL particles. Here is the ion mobility. On the y-axis is the concentration, and on the x-axis is the size. So you go from gigantic on the right to smaller, smaller, smaller as you go to the left. Obviously, IDLs and LDLs are smaller than VLDLs. But look at the concentration. You almost can't see the concentration of VLDLs or IDLs. There's a little bit of bump for the LDLs. The HDL-P, though, is astronomical, and it vastly exceeds the LDL particle count or the VLDL particle count. And by the way, the ion mobility, through sophisticated deconvolution of their signals that they get, they can give you concentrations of the various HDL subspecies, but they report it in nanomoles per liter, unlike NMRs, which report them in micromoles per liter. So here we go. HDL particles are 90% of all of the lipoproteins in your plasma. I bet you didn't know that. LDL-P is reported in nanomoles per liter. HDL particles on NMR is micromoles per liter. 1 micromole is 1,000 nanomoles. So the average HDL particle carries 45 molecules of cholesterol. The average LDL particle carries 2,500 cholesterol molecules. The average LDL-P is 1,200 nanomoles. The average HDL-P reported by NMR is 35 to 38 micromoles. But if you convert that to nanomoles, you have 35 to 38,000 nanomoles of HDL particles. So there are 30 times more HDL particles than LDL particles in your plasma. Normally composed HDLs carry very few triglyceride molecules. That's why HDLs are so small. You need big lipoproteins to carry trigs. But as HDL trigs go up, HDL cholesterol goes down. And this is why, as people get increased triglycerides, insulin-resistant MET, SIN, diabetes, they have low HDL cholesterol because their HDLs are now carrying trigs. And those HDLs are rapidly catabolized and eliminated. So when you have triglyceride-rich HDLs, you have decreased HDL particle count, decreased total HDL cholesterol, but increased ApoB because the trigs came from the ApoB particles. And thus, when you see people with low HDL cholesterol, their cardiovascular risk is not per se related to the low HDL cholesterol. That's just a marker that should suggest to you that, oh my God, ApoB is through the roof in this patient. And the way to properly treat people with low HDL cholesterol is to lower ApoB. And if you're not doing that, then lower non-HDL cholesterol. And once again, there is absolutely no HDL-C goal of therapy in any guideline. Look, as HDL cholesterol goes down, 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 HDL cholesterol goes up and then levels off. LDL particle count goes up, up, up. And you can see at an HDL cholesterol below 40, you're in the high risk LDL particle count or ApoB. And this demonstrates why ApoB or LDLP is the goal of therapy when you treat patients with low HDL cholesterol. Trigs, it's the massive trigs in all of the lipoproteins floating around your plasma. There it is. And most of the trigs are in the ApoB particles. In fact, the vast majority are in your VLDL particles, very few in the HDL particles. So how does the labs assay it? There's a triglyceride molecule. They subject it to a lipid, which cleaves off glycerol. They then measure the glycerol. We know the molecular weight of glycerol. That would tell us how many molecules of glycerol there are. And since the fatty acids attached to glycerol, you can convert glycerol molar concentration using an average triglyceride molar concentration to Cudger's triglyceride levels. If you are a rare person who has glycerol kinase deficiency, you have very high levels of glycerol, the labs will report that your triglycerides are through the roof, but they are not. Your glycerol is through the roof. Thank goodness that's a minority of patients. And this is the Canadian and the United States would be like a distribution of triglyceride levels. You can see above 310, you're in the 95th percentile. The first people who discovered the risk of triglycerides were women at Yale University in the Yale University hospitals. Margaret Albrink was the MD, Evelyn Mann was the PhD laboratorium. And they reported in the Yale New Haven Hospital, elevations of triglycerides above 160 was only seen in 5% of normal young adults, in at most 30% of men over 50. But a trig above 160 was found in 80 to 90% of the people with coronary disease. And they noted few, if any, other lipid measurements have ever had that type of association with atherosclerosis. Mike Miller, my buddy, a triglyceride genius in 1998, published something called the Baltimore Colt Observational Long-Term Study, called the Colts Study. Wonder where he got that name. And he said, what is the prevalence without new coronary disease after 18 years? Let's see, does triglycerides matter? And those who had trigs under 100 had much better survival than those with trigs above 100, which shows you what we now know from the Arick and Framingham studies, that if you have a trig much above 82, your risk goes up, 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 and at a trig of 153, it's horrific. So we have to start respecting much lower levels of triglyceride. But remember, your goal of therapy is not to lower trigs per se, or get it to a certain level. It's to get non-HDL-C or ApoB to goal. Very interesting article. After Mike Miller and NSEP published their, on the left, what the triglyceride classification would be, the Endocrine Society added different levels of risk. And you can see they had different levels to what they called borderline high, high trigs, very high, and added a new category called very high trigs, greater than 2,000. This is a very interesting article. And it's an Israeli study looking at over 250,000 people, and they separated out of the people over the years who had a triglyceride level greater than 1,000 milligrams per deciliter. And then they also looked at how many had trigs between 2,000 and 3,000, and how many had trigs over 3,000. Well, you can see of the people with trigs above 1,000, 84% were in the 1,000 to 2,000 range. A minority had trigs above 2,000 to 3,000, and only a handful had levels above 3,000. But did it matter? Well, it did matter with pancreatitis, so you can see, but it takes really, really high triglycerides to give you pancreatitis. We're all told, hey, at a trig of 500, you're going to get pancreatitis. It's possible, but the incidence would be very low, as you can see. This is even better. So they looked at the red, triglycerides greater than 500, blue, triglycerides less than 500, and they looked at what is the incidence of pancreatitis, MI, and stroke. You can see the incidence of pancreatitis definitely went up, but the incidence of myocardial infarction went down, and the incidence of stroke went down. And if you look at the p-values, yes, there was a statistically significant increase in triglycerides with triglycerides that are elevated, but there's actually non-significant p-value decreases in MI and stroke. And this shows it better. How about all-cause death? Well, if we see how many deaths occurred in the people with trigs between 1,000 and 1,100, we're going to compare the superhit trigs to it. It looks like there's actually less all-cause death in those few people that had the monstrous triglyceride levels. The one reached borderline statistical significance. The other one did not. So as trigs go up, LDL cholesterol goes up and then levels off, but ApoB or LDL particle count goes through the roof, and a trig of 150 are likely to have a high risk ApoB. And that's why ApoB is the goal of therapy when you treat triglycerides. But why the discordance there? Why does LDL cholesterol start going down? Because as the trigs goes up, the LDLs are carrying more trigs and less cholesterol. Non-HDL cholesterol, the mass of cholesterol within all of the molecules in plasma. It's basically your ApoB cholesterol. It is the cholesterol that is not within your HDL particles. Simply subtract HDL cholesterol from total cholesterol, easy calculation. And it's a guesstimate of ApoB, but it's a much better guesstimate than is LDL cholesterol. Like LDL-C, non-HDL-C correlates with, but is sometimes discordant with ApoB. So let me wrap up this monstrous talk. In summary, lipoproteins can be evaluated by their surface charge electrophoretic mobility on gels, paper, or air spray chambers. Lipoproteins can be evaluated by their density in a centrifuge. Lipoproteins can be evaluated by their apoproteins, their proteomic analysis. Lipoproteins can be evaluated by magnetic resonance spectroscopic signals. Lipoproteins can be evaluated by their neutral lipid content, cholesterol and triglycerides. Lipoproteins can be evaluated by size by electron microscopy. Showing you a graphic version of the same things for all the lipoproteins. You see ApoB, you see ApoA1, you see ApoE. Plasma lipoproteins can also be separated in centrifuge, and there are the densities that relate to each family of lipoproteins. You see it goes from very low density that float on the left to very high density that sinks. What makes a lipoprotein float? The lipid content. HDLs, which have so few lipids, they sink. They're carrying mostly proteins and very few lipids. Particle diameters, we know what the diameters. Anything under 70 nanometers can go into your artery wall. Slide, and just look at it. These are the metrics you have to know. Total ApoB, VLDL particle concentration, IDL particle concentration, LDL particle concentration, LDL cholesterol, non-HDL cholesterol or ApoB cholesterol. You see VLDL cholesterol, that's triglycerides divided by 5. You can measure HDL particle count or HDL cholesterol. You can measure ApoA1 if you want to. Fasting is not required for total cholesterol, non-HDL cholesterol, direct LDL cholesterol, ApoB, LDL particle counts, or LDL particle counts. Fasting is required for calculated LDL cholesterol. So I hope you all enjoyed this. Please follow me on X at Dr. Lipid, or if you're a medical professional, you can follow me on LinkedIn. So I went a little bit over time, but I hope it was a lot of great information. The next subsequent lectures will be a tad shorter. So I say good night, everybody, or good day wherever you are.
Thanks, Dr. Dayspring. Thanks for such an awesome, insightful presentation. So much great information. Everyone participating, next week, the presentation will be on lipoprotein A and
little
lipoprotein A, excuse me. And
it's called little lipoprotein little a. Lipoprotein capital A is an HDL particle.
Interesting. Thanks.
We'll get into
it. Thanks. I appreciate that knowledge. Everyone, again, Dr. Dayspring, I know we're both on the East Coast. I want to wish you a good evening. get a good sleep, and I look forward to talking to you next week. And everyone participating, thank you again so much. Everyone take care of yourself. Doc, take care. Thank you so much.
Take care.
Bye-bye. Thank you.